Elias Mossialos is Professor of Health Policy at the London School of Economics at LSE. He's also Professor of Health Policy and Management at Imperial College London. And his research interests concentrate on health systems and policy. Elias has advised organizations such as WHO, European Parliament, European Commission, World Bank, and various ministries of health. So for our team, he is an important person, and we shall carefully listen to him, and he will share with us his insights in how countries can bend the cost curve and how difficult that is. So he will look from the outside to the Netherlands, and I'm really, well, let's see what you are going to make of it in the next 20 minutes. The floor is yours.
Thank you very much for inviting me to participate in your very important conference and interact with you on issues related to cost containment and financial sustainability. Let me start my presentation by outlining what I'm going to do today. I will start with some methodological questions. What is a good cost containment strategy, and try to describe it. Then I will move on to describe a number of frameworks for analyzing cost containment and financial sustainability. And then from there on, focus on multimorbidity, as previous speakers have done, and focus on two key issues. How can we improve our workforce? This is a supply side. And then how can we intervene with the demand side by introducing whole population management systems in order to improve population health and reduce need for healthcare services. But let me start with a conceptual framework. What is one of the key objectives in our healthcare systems? There are many multiple objectives, of course, to improve equity, to offer financial protection to our citizens, also have systems responsive to the needs of the consumers. But if we don't improve efficiency and we don't bend the cost of healthcare, then we will not be in a position to satisfy all other key objectives. So the objective of efficiency is to improve overall population health. And how can we achieve this? We can achieve this by both containing costs, but also by increasing costs. And this might sound paradoxical to some of you. How can we do that by containing costs and at the same time increasing costs? We can do that because by containing costs, we can reduce low-value care. So if you reduce low-value care, you can use this money in order to improve access to healthcare services. That means increasing costs, so therefore improving efficiency. Because if you have significant unmet need in a particular country, then you will have to increase spending. Access to services which are not currently provided, access to medicines which are currently expensive and not fully reimbursed. But a good cost containment strategy, therefore, will be to reduce low-value care. But if you reduce necessary care by containing costs, this is not efficient. On the other hand, if you increase costs to finance necessary care, this is efficient. If you increase costs to pay for low-value care, this is very inefficient. Now, is it all technical? Is it all about economics? But is it a little bit more complicated? Look at this very simple equation. On the left side, as you look at this, we have the sources of funding. You have taxation, insurance contributions, private medical insurance contributions, and out-of-pocket spending on user charges. This equals to prices times quantities. And this also equals revenue to wages times inputs. So if you reduce revenue, if you reduce contributions, if you reduce taxes or user charges, this is likely to have an impact on the other parts of the equation. Then you'll have to reduce services, quantities, or reduce prices, or reduce wages, or reduce employment in the healthcare sector. So this is the political economy of healthcare. So €1 that is being reduced somewhere in the healthcare system will have an impact somewhere else in the healthcare system. And of course, powerful interests, pharmaceutical industry, for example, will be against reducing prices. The medical profession will be against reducing their prices, their revenue, and their wages. So we cannot look at cost containment policies and financial sustainability policies out of the context of politics in the country, out of the context of vested interests in a particular country. Then we have to be faced with the politicians and the political reality. In most political debates, policymakers are not focusing on objectives, unfortunately. They are focusing on means on how to improve the healthcare system. For example, how to pay the doctor, how to pay the hospital, how to fix the prices in the pharmaceutical sector in the diagnostics. But we first need to define our objectives. What are we trying to achieve? Is the objective to improve equity? Then let's discuss about the means of achieving this. Or is the objective to improve efficiency? Or both? And if it is both, what are the acceptable trade-offs? What are the acceptable inefficiencies? For example, locating a service in a remote area, in northern Netherlands, for example, which might be inefficient from an economic perspective, but satisfies the objective of equity, or concentrating services for specialized services in the southern part of the country because this is more efficient to have economies of scale. Then many politicians are interested in here and now. That's about politics. How much are we going to spend? This is the question of a minister. The minister will never or very rarely ask whether we should spend on a particular service, because in the future we're going to see the benefits. But in the future there may be another minister in place or a different government which might benefit from the whether question rather than the how much question. Then, as I said before, many people confuse cost containment with efficiency, and this is wrong. So you can contain costs and suppress efficiency if you contain necessary healthcare services. And finally, should we spend more on healthcare services? Well, it depends. If we are going to increase the health status of the population by spending more on health services, then we should. But if other alternatives contributing to the health sector or to the health status of our people are more important, then we should also consider them. So we need to look into alternatives and allocative efficiency. So how to allocate our resources, our public budget, to the different government functions, from health to environment to housing to education to social welfare and social care, which might improve overall population health. And you do all this thinking, and then you get different perspectives. You have very diverse perspectives in healthcare systems. The service users are interested in promoting patient choice and empowerment. Professionals are seeking to improve their working conditions and their revenue, of course. The managers and the insurers to secure better managerial and cost control of healthcare organizations. The politicians to secure better political control of the healthcare system. Citizens to assure value for money and accountability. And regulators are acting as expert intermediaries on behalf of citizens. And finally, researchers like me are helping to identify what works. And if we fail to identify what works, then we finish our papers by saying more research is needed, and please give us more funding to conduct this research. Yeah, 90% of the papers are finishing with more research is needed. Now, this is leading to a significant diversity in terms of interest in different aspects of health systems performance, interest in different levels of detail. You have seen your permanent secretary referring to the 500 pages. I have to say, in a previous life, I was a Minister of State in my country of origin, introduced the Social Security reform 7 years ago, and I asked the members of my cabinet to start the day by preparing one-page briefing of the important key issues of the day. And they found it extremely difficult. They were all university researchers, so they could not contain themselves to one page. So you can see the different political perspective. My advice to you is translate all this brilliant work into policy notes and policy briefs for your ministers, the Prime Minister, and the top people in government. They cannot afford to read more than 2 or 3 or 5 pages. Now, so therefore, there are different methods of analysis, different methods of presentations to the political community, and different priorities attached to timelines. We researchers, we can take 2 or 3 years to write books and nice papers. For politicians, a week in politics is a very long period. And of course, comprehensiveness is different and precision is different. So politicians are about making things happen here and now. So we have to help them with their work. Whatever the different perspectives are, there are 4 key challenges we need to address, all of us. Where to find the additional public funding? By cutting spending on other public services? This would be faced with opposition from everybody in government apart from the Minister of Health. So therefore we need to face reality, probably raise further insurance contributions. This may have a knock-on effect on employment, however, or foreign direct investment. How to ensure that additional funding is well targeted at greatest need. We're not just spending more money, but we're targeting those in greatest need. How to ensure that funding is used efficiently and unjustified variations are substantially reduced, variations across different geographical parts of the country or population subgroups. And how can we assure that the system does not cost more than it should cost? And here we need to look into international comparisons. How much are you spending here compared to other countries? What do we know? We know that static efficiency may improve at the cost of a dynamic efficiency. So you want to contain costs in a particular financial year. You can establish budgets, crude budgets. If you don't risk adjust your budgets, then you run the risk that there may be risk selection in the healthcare system. So vulnerable patients and frail patients might not be treated well. You raise user charges, you contain demand for healthcare services because demand is going to be reduced, most likely from the lower socioeconomic groups. You reduce expenditure. This comes at the expense of the dynamic efficiency because the severity of the diseases of the low socioeconomic groups people is going to increase, and therefore they're going to utilize more healthcare services in the future. Second important issue that we know, disinvestment. All habits die hard. So medical professionals are not giving up on established practices. And they're not always kept updated with what is new in medicine. But our regulatory system is also organized in a way to focus on new technologies and new interventions rather than on disinvesting old interventions which may not be as efficient as new interventions. And this is coming at the cost of welfare loss, of late adoption of policy innovations, and appropriate new medical technologies. So what we're currently doing in order to contain costs and sustain financial prospects in our healthcare systems. So we're trying to interfere in a triangle, more or less, a triangle including two principals and one agent. The two principals, people and patients, and the payers. These are the two principals. And the two principals, what they have done in the past 40 or 50 years with the introduction of healthcare systems, is to delegate power and the decision-making regarding treatment to the agents, our hospitals and our medical professionals, pharmacists, nurses, and allied healthcare professionals. So they gave up power. And then they realized that probably professionals became very, very powerful, and they had also monopolistic situations in countries which are under-doctored. And there are several countries where there are not enough doctors, and therefore there are monopolistic situations in the market. So both principles, therefore, aligned their interests in the past 20 years to take power back. And how they took power back? The principal patient through choice. So by choosing insurers, but also choosing providers of healthcare services, and therefore creating contestability in both the insurance market, as you do here in your country, and also in the provision of healthcare services. The payers' principles reasserted powers on providers, hospitals, and doctors by imposing budgets on them, by fixing prices, and also by measuring quality and performance, and in several countries by naming and shaming underperforming providers. It's all about managing risks, because what happens when you're introducing budgets? When you're introducing budgets to a group of doctors, or you're introducing budgets to an insurance company, how is the insurance company or the group of doctors are going to behave? Like private medical insurers. They will try to attract the better risks. They will try to attract the better risks in the insurance function in the population attached to a general practitioner's practice or a group of doctors' practice, because if they attract the better risks, their cost structure is going to be very favorable. So if they can dump the high risks to other doctors, other insurers, then they are not having financial problems. And in this country, what you have done is, and rightly so, you introduce very good risk adjustment systems in your insurance system to mitigate the potential for risk selection. Not fully mitigated, because the best risk adjustment systems can predict up to 40 or 50% of future utilization of healthcare services. And we're doing the same when we're allocating budgets to doctors. We are risk adjusting them because we don't want doctors to behave like insurers. If they are faced with a crude budget, they will try to attract the good risks. If they get a risk-adjusted budget, so that the higher risks attracting more funding, then the doctors will not have an incentive, this is the theory at least, to underservice the more vulnerable people in our societies. And then we have experimenting with risk management regarding hospitals. But there the objective was not initially to contain costs. The objective was to increase productivity. And that's why we introduced activity-related payments. And they're called DRGs, diagnostic-related groups. So therefore, there is a kind of risk adjustment because we're fixing the payment per admission, taking into account the patient's diagnosis and age and gender characteristics. And in some countries also, we are considering secondary diagnosis. But no, we are not doing very well with risk adjustment there. Why? Because the majority of the patients admitted to hospitals are multimorbid patients. And therefore, by only considering a couple of diagnoses and all the full spectrum of their conditions, we're not properly risk adjusting hospital payments. Now, we're all doing all these things, so therefore the two principles, the payers and the insurees, the customers of healthcare services, the patients, have reasserted their power by introducing choice and also controlling doctors, the insurers. But this may come at a cost. So over-regulation of the medical profession and over-regulation of providers may come at a cost in the future, and we need to consider it carefully. Because in Europe, there is a shortage of 1 million healthcare workers now, and there are emerging countries now and with healthcare systems all over the world. India is offering a better healthcare system to its citizens. Many countries in Southeast Asia are prospering, so there will be less possibilities to attract medical professionals from other countries. So we'll have to be a little bit careful in order not to end up with under-doctor countries, and in this situation we'll be faced with monopolistic situations in the supply of healthcare services, rather than possibilities to increase choice and also to increase the services for the multimorbid patients. So how do you compare to other countries? You can look here at the spectrum of 11 industrialized countries, and you compare well to all of them. You compare well to neighboring countries which have also introduced competitive insurance systems, such as Germany and Switzerland, and you compare well also to tax-funded systems, such as Sweden and Britain. Of course, I'm not including in this data your social care costs, which are very high, much higher compared to all these countries. You spend about 3 to 3.5% of your GDP on social care, and this percentage is much lower in other countries. But this might have an impact, the fact that you're spending more on social care, on reducing healthcare costs. What is notable here as well is the level of private funding in your country. And this is very good. It's the lowest across all these developed countries. And you can see it here as well in some more detail. You are the last in terms of private funding, in terms of out-of-pocket expenditure. That implies that financial protection in the Netherlands is very high. And also in terms of the percentage of the household income spent on healthcare through out-of-pocket expenditure, again, you're the last. Only 1.3% of the household income is spent on healthcare services. So very high financial protection in the Netherlands. What about utilization? Again, if you look at the utilization of hospitals, you are below the mean of all these countries. A bit higher, compare consultations with physicians, but below the mean in terms of average length of stay in hospitals. If you look at your utilization of MRI and CT scans, here at the bottom of the distribution, which implies that waste, at least for diagnostics, this is indirect evidence, is not very high in your country. And in terms of avoidable hospitalizations, you're doing well in terms of diabetes, even if we take account the prevalence of diabetes in your country and standardize for this, but you're not doing as well. You're doing better than most of the countries, as well in the case of asthma, because as you all know, the problem with the management of asthma is a cyclical disease. Adherence to medication there is very important. So patients may not adhere to medication, and therefore we do need to educate patients in order to take their medication. So you can do better there. But what are the key problems we're going to be faced with in the future? We're treating our patients too late. So doctors are waiting in their offices for the patients to turn up. Hospitals are waiting for referrals from primary care practitioners or for emergency cases. We're unsure of what does work in healthcare, and we're mostly focusing on new technologies rather than old technologies. We treat all people the same. practice guidelines are nice as a cost containment method, but practice guidelines may restrict the possibility of focusing on complex cases, and most practice guidelines are focusing on a single disease rather than on patients who are suffering from multimorbidities. And therefore, we have to consider now the new world, not those suffering from one disease, but those suffering from multiple diseases. Medical errors are often not noticed and not measured. And most medical errors can be attributed to systems rather than individual doctors and nurses and healthcare professionals. It's a system design that it is wrong. Variability of care is significant, not only across countries, but also within the same country. Nonsensible workflows in most healthcare systems. Doctors handing over to other doctors 7 o'clock or 6 o'clock in the morning, not finding time to explain what has happened in the previous 12 hours. Same with nurses. Making patients arrive at our silos, being very protective and protectionist of our silos, our specializations. In many hospitals now, there are more than 50 or 55 sub-specializations. But the patients admitted to hospitals are multimorbid. So how can we get doctors to work in teams without sacrificing their autonomy in terms of their specialization? And we do whatever we do, and patients are ignoring our advice. 50% of patients suffering from hypertension are giving up medication within a year. Same with the asthmatic patients. 50% of those who are suffering from a heart attack will give up medication within a year. 25% of them will die the year after. So we're not doing well there in terms of engaging patients. So what we should do, therefore, so we do need to be more proactive. How can we incentivize our professionals to engage in preventative activities, not only primary prevention, for example, vaccinations, but secondary prevention, prescribe statins, which are useful for those who have high cholesterol levels, or tertiary prevention, how we're managing the patient after a heart attack or after a stroke. Then we need to find out what works. And not only about the new technologies, but also the old technologies. And are we sending the right signals to the pharmaceutical industry as well to partially shift from developing treatments to developing cures? You're all familiar with the hepatitis C drugs and the havoc that has been created in the past few years regarding the high prices of hepatitis C drugs. But we need more of these kind of innovations. So let's leave the price out for the time being, but we need more drugs. Imagine a pharmaceutical company coming up with a cure for diabetes type 1. How are we going to address this problem in our markets? And we don't know. Now, moving on, the distribution of healthcare costs. You have already referred to this, the brilliant Dutch research presented before. 1% of our patients consume 27% of healthcare costs, and 10%, 69% of healthcare costs. This is from the US. If you look at Ontario in Canada, 10% of the patients consume 77% of total healthcare costs. So then you look at this brilliant Scottish data. As we get older, the probability of developing more diseases is higher. By the age of 50, 1 or 2 of us will have at least one chronic condition. You present this data to the Minister of Health, the Minister of Health starts to panic, and they move and go to the Minister of Finance, they talk to the Minister of Finance, and they ask more money because there is a problem with older people in our societies. So the Minister of Finance will start panicking, will say, I'm not interested in the old people, I'm interested in the productive people in our societies. Cynical response. So therefore, I'm not going to pay for the old people in the society. After all, they are going to increase the pensions budget if they live longer. Sorry to be cynical, but this is the typical Minister of Finance response, not in public, but in closed doors. Now, you have this nice discussion, but then you need to find more ammunition for your Minister of Health, and then you present this Canadian data. And if you look at this Canadian data, and you see the difference between 2003 and 2009, you can see that multimorbidity is concentrated at younger ages. The big burden of multimorbidity is in the productive ages, between 30 and 65. We have more people with multimorbidities as we get older, but the probability of dying, of course, is much higher. So this is the right argument for the Minister of Finance. If we don't invest in secondary and tertiary prevention, then we are all doomed in terms of the sustainability of healthcare systems. And there is also an equity argument, because multimorbidity is concentrated mostly in more deprived areas. So if you're interested in equity in healthcare systems, then we should also focus in more deprived areas. And take that as well, which is related to mental health, which is mostly neglected in many countries. And mental health is not integrated with physical health. But there is a powerful economic argument. Look at people who are suffering from diabetes or COPD or many other diseases, and a mental problem. The rising costs, up to 186 for COPD, a respiratory disease. So what are the solutions, therefore? Will one size fit it all? No, because there are different expectations in different phases of our lives. In the ages between 65 and 84, the problem is social isolation. But in the ages between 45 and 64, the problem is with diminishing social support and multiple roles and demands. Making higher incomes, try to get our children into universities, make provision for our older parents. So we do need to, in order to bend the cost of healthcare services, to focus on both the supply and the demand of healthcare services. Very briefly, I'm finishing. For the supply of healthcare services, we do need a different workforce. We cannot just plan on the basis of historical trends. The situation is changing. We have multimodal patients. We need doctors with more diverse specializations and more diverse knowledge. Doctors and healthcare professionals, nurses, paramedics, medical assistants, who are qualified and they have the right skill mix that enhances equity of access to care, focuses on prevention, matches demands in terms of place and care of delivery, works in partnerships, doctors with nurses and healthcare professionals, and promotes self-management of care for the patients, demonstrates adaptability and flexibility because the world is changing, and embraces shifting role boundaries and new roles. And then what about future needs for healthcare? Are we all doomed? Probably not. The aging of the population will create more pressures to healthcare and social care. Falling birth rates in some countries will have implications for the future workforce. Levels of immigration, if they decline, will also have an impact on the workforce. However, the impact should not be exacerbated. Given the healthier cohorts of the aging population, we have emerging research in some countries in Europe pointing to a direction there is falling dementia in the aging population, and many older people are re-entering the workforce. So it's not all doomed, I'm arguing, and there are huge possibilities in terms of prevention. But even in prevention, we're working in silos. We have different people focusing on alcohol, different people focusing on changing dietary patterns, different people focusing on tobacco reduction consumption. So we need to have a consolidated single preventative strategy. To conclude, future healthcare systems are going to be different. We need to move from the current systems, which are focusing on single contracts of providers, into collaborations between providers. Provider-to-provider contract will become the norm in the future, integrated care models. Currently, money follows the organization. Money should follow the patient, or should follow special patient categories. For example, cancer patients, who have to be treated not only by our hospitals, but we do need to have psychological support, nutritional support, out-of-care, out-of-hospital support, 24 hours access to services, because the problems are very complex. We have to understand costs not at the provider level as we are currently understanding this, the cost for primary care, the cost for pharmacy care, the cost for primary care, but costs at the patient level. And finally, we need leadership that will take into account the whole population health perspective, because our current leaders, our CEOs, are currently focusing on their organization. Nobody is caring about the whole population health perspective in a particular region of the country. So, what is the future and how is this going to look like? From my perspective, we can do better. And I'm not one of those people who think that the situation is going to be catastrophic. But we have to recognize that healthcare systems perform multiple and complex functions. One size will not fit it all. At the same time, we have to recognize that history and values are also important. What people think that it is important, we have to consider it very seriously. And politics is always interfering with the decision-making process. And the decision-making process, don't expect this to be always academic and scientific. As Otto von Bismarck once said before the Prussian parliament, if I remember well, this was in 1861, politics is not an exact science. So you have to deal, therefore, with a political spectrum. No one anywhere in the world has all the answers, and improvements are more likely to come from doing a lot of things well rather than a single thing here and now. Thank you very much for your attention.
Thank you very much, Elias. So we will press you for time a bit.
Yeah,
You have a lot of interesting information. Gave us a broad reflection on the healthcare systems in the world from lots of different perspectives. Some nice quotes also. Politics is about making things happen here and now. And we are doomed if we don't invest in secondary and tertiary prevention. We will take these issues up on our discussion later. Thank you very much.
Thank you.